Kia ora team, my name's Ben and let's look at our Ottawa Ankle and Foot rules to see if we can exclude fractures in acute ankle and foot injuries. To start off, we'll do some palpation, then we'll look and assess the sensitivity and specificity of the Ottawa Ankle and Foot rules. Okay, what are they? X-ray is required if any of these things are true. Bony tenderness at the posterior edge or tip of our medial and lateral malleolus and 6 centimeters up, and if they have inability to weight bear both immediately and in the emergency department for 4 steps, and then down on the foot, bony tenderness at the base of our 5th metatarsal and our navicular. Let's bring up the bones. Our lateral and medial malleolus aren't too difficult to palpate. Basically, a malleolus is a bumpity bit on the inside or outside the ankle. If we remove the skin, we can see on the lateral aspect, there we have our lateral malleolus, and on the medial aspect, the medial malleolus. They're the bumpity bits, and we're going to palpate posteriorly and then 6 centimeters following up there. Any tenderness is an indication for an X-ray. And then in the foot, we've got the base of the 5th metatarsal. So how we find this is we start labeling our metatarsals from our big toe. So the 5th metatarsal is going to be lateral. And you can see we've got tendons running down to insert onto them. So we can either trace it from the little toe and come back until we feel that bump at the base, or we can come from the calcaneus and the heel and come forward until we find that bump, which is approximately the middle of the foot. So that's the base of our 5th metatarsal. Then the other bone is the navicular. This is the medial cuneiform, and this one here is our navicular. If you palpate the medial malleolus, and then it's about a thumb's width down, that would be the talus. And after a thumb, we meet the navicular. So tenderness through the navicular would indicate the need for a X-ray, and tenderness at the base of the 5th metatarsal. Then our lateral malleolus and our medial malleolus. Brilliant. So now, if we look at how good the Ottawa ankle rules are at actually picking up fractures. So their sensitivity came out as a pooled 91% in the meta-analysis. So this means out of 100 patients who do have an ankle fracture, then 91 will be correctly testing positive under our Ottawa ankle rules. So we're going to get approximately 9% false negatives. It's quite good, but not as good as our knee rules. It's still strong for ruling out ankle fractures when negative, because remember, snout. Sensitivity, if negative, is good at ruling out a fracture. And then specificity came at around 25%. So out of 100 patients who don't have an ankle fracture, only 25 will correctly test negative. That's meaning we get 75% false positives. This means a large number of patients without a fracture will still meet the criteria and be sent for X-ray. Clinically, positive results do not confirm a fracture, so we still need imaging to confirm. It's okay for these rules to be intentionally broad, because we don't want to miss fracture. So a low specificity is an acceptable trade-off. Overall, our ankle and foot rules are great for ruling out fractures, but they generate lots of false positives. But this is something that is probably okay to accept. We are going to get approximately 9% false negatives, so it's still important to use your clinical judgment to make sure we do X-ray when required. All right, team. Happy studying.